we'll let some people file in here. And we're excited for Dr. Goodman to join us today. Just some quick housekeeping notes. There's going to be the Q&A tab as well as the chat tab on the user menu. And if you have questions as we begin or throughout the duration of the lecture, make sure just to jot those down. Some people have sent questions in ahead of time, and I will have those answered by Dr. Goodman at the end of it. In the meantime, just kind of sit back and enjoy the presentation. So let me tell you a little bit about Dr. Goodman. We met, I guess, about 4 or 5 months ago now, and he has joined the group at Evergreen Orthopedic and Sports Care and works with a number of friends of mine, Dr. Camille Clinton, Mike Codsey, one of our former aides, Katie Hall. So a really fun group up at Evergreen, originally from Northern California, did his undergrad work at the University of California, Davis. Great location, great school. And then headed off to medical school at Case Western University in Ohio, where he then later did some residencies at a couple of very well-known universities in the Ivy League, Brown University, Harvard, and then also did some work at Mass Gen, which has a really strong PT program as well. Fellowship trained in upper extremity. Basically, I like the line on your website, basically everything from arm to fingertip. And I think for so many of our athletes, whether it be CrossFit, whether it be yoga, whether it be baseball, and many others, this is something that really fits well into the niche of the practice, especially this time of year. So without further ado, we're excited to have you here. I'm excited for the group that you joined, but also we're looking forward to kind of continuing to collaborate with you over the coming years.
Absolutely. Thank you very much for having me, Ben. Really appreciate it. So like he said, my name is Avi Goodman. I practice at Evergreen, and the talk today will be returning to play, sports injuries of the hand, wrist, and elbow. So a little bit of a roadmap for today. So thank you very much either for joining us live or for watching at double speed later. I really appreciate it. And again, I really want to thank Ben and the whole Lake Washington PT team, not only for graciously having me here today, but also for taking great care of patients through the Eastside and also through the greater Seattle region. So today I'd like to talk about athletic injuries of the upper extremity, but that's a very broad topic. And so we're going to focus a little bit on a few key injuries for each for the hand, wrist, and elbow. So a little bit about me to start. Again, my name is Avi Goodman. I am a native of the West Coast. I grew up in the Bay Area. Went to school down there at UC Davis. Then I moved to the Midwest, where I went to medical school at Case Western in Cleveland. I then went to my orthopedic residency at Brown and Rhode Island Hospital, and that's in Providence, Rhode Island. I stayed there for my fellowship in orthopedic trauma, and then went just a little bit farther north up to Brigham and Women's, Boston Children's, and MGH for my hand and upper extremity fellowship. And now I landed in practice at Evergreen Health in Kirkland, which is a wonderful facility and a wonderful group. So we're right here in Totem Lake, where there's a great, just a great new region and really a good new facility here that we have. So to jump into it now, the first thing is my hand hurts. So one of the injuries that we commonly see is the mallet finger, or the so-called baseball finger. And this really occurs when something strikes the tip of the finger and bends that finger down, which ruptures either the extensor tendon or ruptures the bone to which the extensor tendon is connected. And this leads to a droopy fingertip, which will stay this way unless it's corrected. Most of the treatment, fortunately, is non-surgical, and that means that we hold the fingertip straight with a splint for about 8 weeks. The aggravating thing is this needs to be done full-time, like totally full-time, 24/7. And if this is done, it usually heals very well. Sometimes it's a little bit of a droop, but usually this is not functionally limiting. But sometimes we will think about surgery, but that's really just if the bone is shifted down so that joint is subluxated, will we think about surgery. And if we do that, typically we do that with a pin to hold the joint straight. thinking about the return to play, that really depends on the position and on the demands and also on the particular finger involved. Sometimes athletes will be able to wear a bigger brace and to have that totally isolated and will be able to do their sport, whereas others, it may be really significantly limiting. So this really depends on the positions and demands. Just want to show, this is an example from one of my patients recently who had a bony mallet fracture that we can see right here. And there we can see that because that joint is located, we can treat him non-operatively. And so they'll go on to hopefully at least it's a good result. If not a complete bony union, then he'll have a good mobile fingertip that doesn't have much of a droop and doesn't have much subluxation. So another injury that we treat are flexor tendon injuries, and these can either be closed injuries, like where the tendon ruptures because the hand is extended against resistance, or it can be from a laceration, and that can happen with things like hockey or anytime that there's a sharp cut or laceration. One of the other reasons that I bring this up is it can be a very bad injury, and more so than it initially appears. The tendons can retract, they have issues with vascularity, and more importantly, these tendons and hands can become really quite stiff. There have been quite a few differences, or quite a few changes in technique of repair over the past number of years that have really changed the game as far as rehab as well as their outcome, which has really improved our outcome. So here's a picture on the right of a patient who had a small finger laceration of both of the flexor tendons. And what I always tell patients of, for me in the OR, it's 2 hours of hard work. And for you, this is 2 months or more of hard work because there's lots and lots of rehab to be done. One of the neat techniques that I like to do is I like to have the patients wake up or at least be able to move at the end of the surgery once the repair is complete. So then we can really test this. So here's an intraoperative video. If you're squeamish or eating lunch, you may want to look away for a minute because there is a little bit of blood involved, but otherwise it's kind of cool. So this is a patient who had lacerations of both tendons in the pinky finger as well as both tendons in the ring finger. And here we are asking them to move it. So let's see if this video will play. And it looks like it won't, but basically what the goal is during the surgery is to have them be able to move it. It's also a really helpful thing for the patient as well as the therapist to see, because we can show them you were able to do this during surgery, so this is our goal for you to get back to doing. Here's the video playing. And so the patients are very, very impressed by this because it's very challenging to regain this, and so that's a great therapeutic tool. So another hand-specific injury is a fracture of the hook of the hamate, which is oftentimes seen in the context of sports. The hook of the hamate is the bone that's palpable right about here, so in line with the ring finger, and it sticks up three-dimensionally, which is why it's at risk for a fracture. We can see here on the left, a patient holding a racket, and this racket can bang into it, especially if they're holding a racket and they hit a wall or they hit the ground. There's a lot of force that goes directly into here, or it can be caused by a batter having a check swing, and that just puts a tremendous amount of load into that little area. These have a propensity to not heal, which is why we're always a little bit worried about them, as well as they're very close to several important structures, like the flexor tendon to the pinky finger runs right next to it, and then one of the important nerves to the hand runs on the other side of it. And so if the fracture is displaced, it can cause either tendon irritation and potentially rupture, or nerve irritation. And if this is the case, sometimes we'll not try to get it to heal, but we'll just actually take out that fragment doing an excision. And if this is the case, then we can get the athlete to return to sports usually in about 6 weeks, once all the skin and soft tissue heals. And there isn't typically a big deficit from this kind of surgery. Another common injury that we see in sports is an injury to the thumb ulnar collateral ligament, or the UCL. It has the name skier's thumb, but we also see it really in any context where the thumb is hyperabducted like this. And so it can be in the case of skiing if the person is holding a pole and they hit a gate and it goes like that. But you can also see it for patients like baseball players who are sliding into a plate and they get their hand jerked like this, or soccer goalies, or any one of a number of different other possible mechanisms. The patients will usually feel a pop. They may feel like their thumb shifted out of place or not. But the interesting thing is the pain often dissipates in this scenario, and so they may not really think that much of it. If the injury is not complete, so if it's just a partial rupture, then this usually heals well, but with a brace and with changing their activity modification. This can take between 2 and 8 weeks, depending on the severity of their injury. But if the injury is complete and their thumb is very lax, like is seen on this x-ray where the thumb metacarpal is moved over completely, then surgery may be warranted to help restore stability. And the way that we do that is sort of interesting. So with the non-operative, we immobilize this for 4 to 6 weeks. Usually it can be a little bit shorter, it can be a little bit longer. The prognosis is really quite good for returning to sport. But if it is operative and we're able to catch it soon, typically we'll do a repair of this thumb UCL, as well as augment it with something called an internal brace or a very strong suture, which really helps with early rehabilitation. So we get the patients moving early, which helps to minimize the stiffness and as well as maximize the strength. If it's a chronic injury, if patients have had this before, or for some reason they come to us several months later, oftentimes we'll have to reconstruct the ligament with a tendon of theirs as opposed to just repairing it. And the outcomes after this aren't quite as good, but still reasonable. So with us, we really think about the stability aspect of it versus the mobility part of it. And typically return to play is in the neighborhood of 12 weeks, although it could be a little bit shorter or more typically a little bit longer, depending on the player demands. Now moving up a little bit to the wrist. Scaphoid fractures are the most common carpal fracture, especially in contact athletes like football players or hockey players, or those patients who load their wrists in sort of super physiologic conditions like gymnasts. It usually occurs with a fall, typically a fall on an outstretched wrist, but it can be any axial load along the wrist, especially with some component of rotation. The pain is usually along the radial aspect of the wrist, and it can occur with loading of the thumb or pincer grasp. The initial x-rays can be negative, which is why we're always very concerned about it. And so if patients are really complaining about a wrist sprain that seems to be on this side of the hand, give them a little bit more of a checkout and see what's going on. So these are the two places that we really look for. On the left image here is what's so-called the anatomic snuff box. So it's right in there, and it feels like this soft spot in between your two tendons. That's one part of the scaphoid, and then on the right is on the other part, on the palm side of the hand, right here at the base, where this big tendon, this FCR tendon, goes right by. If people have tenderness at both of those spots, it's more likely than not that they would have a scaphoid injury and should be evaluated. Now, the question is, why do we care so much about this, especially as hand surgeons? So first, it's the most common carpal bone fracture, accounting for 70% of these injuries, and including the athletic 15 to 30-year-old populations. So also, it's hard to find. This bone is shaped like a twisted peanut, so it's this complex three-dimensional structure, and again, x-rays are two-dimensional representations of the three-dimensional structure, and so it can be hard to really find this. Next, it's hard to heal. So the scaphoid has a fairly crummy bone supply or blood supply. The blood supply, unlike most bones, runs from the far part to the near part, and as such, as you go from the far part to the near part, it has a lower and lower chance of healing. These distal fractures have a much higher chance, whereas these proximal fractures have a 1 in 4 chance of healing on their own. And then lastly, the other reason that we care so much is if a fracture is missed or it goes on not to heal, there are very severe consequences. It leads to a very predictable pattern of wrist arthritis, which can be quite disabling later in life, and not even that much later, 10 years later. And so if we miss this in an 18-year-old, by the time that athlete is 30, they may have a significantly worse wrist and will be very, very impacted for the rest of their lives. So that's why we care so much about this. So for the evaluation part of it, a prompt evaluation, especially again, if they have pain on the radial aspect of their wrist, is important. If they do, just get them into immobilization, and that's something that immobilizes the wrist as well as the thumb. So a thumb spica brace. Usually folks go to urgent care, they're seen, and then if they still have pain in 2 weeks, we get another x-ray at 2 weeks, because that will be very helpful for reevaluating. Sometimes the fractures can show themselves a little bit more. However, if this is an elite athlete or if return to play is really paramount, we'll think about getting an MRI basically at the time of injury if the original x-rays are not diagnostic. For most people, if there's a concern for the scaphoid injury and the x-rays are still non-diagnostic at 2 weeks, but there's a high clinical suspicion, that's when we'll get an MRI. And then if we need to, the treatment for these are casts. So casting is a good treatment for patients who have non-displaced scaphoid fractures, especially in the distal pole, which again has a better likelihood of healing, but it gets less and less effective the closer you go to the hand. And it has, as long if you have other comorbidities like diabetes or smoking, the likelihood of union goes down and down. So surgery is the other option. Our considerations for this are the fracture patterns of where it is, the patient age, their health, but also their activity level and their sports participation. If they're in their last year of high school sports and they're not planning to play anything in college, this is a little bit different consideration than if they're a D1 athlete who is 3 months out or 3 months ahead of their season. So our treatment for this is generally a screw. So we see here on the right side an X-ray, and there's a scaphoid fracture right through the middle of the scaphoid. This particular patient had been there for about a month or so, and so we see some bony resorption. But we're able to go in and fix this patient's fracture with a screw to really squish it back together, get some bone graft there in the middle, and to try to get everything to heal. And this patient's still in the process of healing, so we'll watch them and we keep our fingers crossed. These are also ones where we have fairly frequent monitoring. We have a low threshold for getting CAT scans to monitor healing, and that can also determine some of our return to play thresholds. And if we get a CAT scan that shows earlier bone healing, much more likely to get them back to playing. So ulnar-sided wrist pain is another great question about athletic injuries. And it's the ulnar side of the wrist, which is again this side of the wrist on the ulna, has long been considered sort of the black box of the wrist, primarily because differentiating all of the different pathologies in a small space can be a challenge. Looking at this, these are some and most of the components of the ulnar side of the wrist, and so we can see that it really is quite high rent territory with a lot going on. And we can think about these ulnar-sided wrist pain into a few different groups. One is was there one particular acute injury, or is this something that's more chronic and more degenerative? Because that really depends on how we treat it. So this is where thinking about paying attention to a patient's history. If they can report something where they had one specific instance that they remember, like a twisting something, and all of a sudden they feel pain on the ulnar aspect of the wrist, maybe they're snapping or popping, that makes us a bit more aggressive about treating them. So the physical exam is key. There's there are many different exam maneuvers for it, but instability is one of our biggest things to warrant further action or intervention. And that can be instability of the ulna, or just instability of the wrist in general, or of the tendons that go around it. So imaging, MRI, so x-rays are important for a first pass, but then MRI or MRI arthrograms are typically the imaging modality of choice, although ultrasound can be done. The pathology of the TFCC or the ECU are typically the most common, although certainly there's quite a few things in the differential diagnosis. Like we see here, they can be thought of as ligamentous pathologies or bony pathologies or tendinous. And because everything is in this area that's about 1 centimeter by 1 centimeter by 1 centimeter, it's really important to pay close attention to the exam and the imaging, but then also really correlate it with the patient's symptoms. Because oftentimes these injuries will heal, or at least they have a reasonable probability of healing. The question is of the timeline, and if the patient's willing to tolerate being either in a splint or a splint that goes up their entire forearm and controls rotation for 6 weeks, then if they're able to tolerate that, then that's a little bit better. Sometimes, though, we will need to do surgery, and this is just one example of a repair of the TFCC, and sometimes we'll need to couple bony procedures with this. Like if the ulna is comparatively too long, that changes how load is transmitted across the wrist and makes it more likely that that side of the wrist is injured. And so if there is an injury, typically we'll do a shortening of that ulna bone to offload that wrist and then do the repair in order to minimize the chance of further injury in the future. So now thinking about the elbow. So a a lot of different injuries in baseball. The most common ones are the medial, or also known as the ulnar collateral ligament sprains or ruptured, valgus extension overload, olecranon stress fractures, flexor tendonitis, and ulnar neuritis. Thinking about flexor tendonitis and ulnar neuritis, the flexor pronator muscles attached to the medial aspect of the elbow, which are here, which you can imagine get quite a workout while throwing. And those can become either acutely injured or they can become chronically inflamed just as there's more and more load placed on the elbow. And that goes hand in hand with ulnar neuritis. The ulnar nerve also goes right behind the elbow and gives us sensation to our pinky finger and usually half of our ring finger, but also innervates a lot of muscles in the hand. That ulnar nerve behind the elbow can become quite inflamed if there's other trauma to the area or just on its own from repeated insult or injury. So thinking a little bit about valgus extension overload and olecranon stress fractures, this is common in throwing athletes. The abnormally high load causes an abnormally high wear of the cartilage, which then results in bone spurring, specifically at the posterior medial aspects of the elbow. And it may also lead to an olecranon stress fracture, as we see here. It may be coupled also with triceps traction force and posterior medial impingement. And these injuries, these olecranon stress fractures, can also be associated with elbow UCL injuries. The first line of treatment for these are typically strict rest for 4 to 6 weeks, but potentially out of sport for up to 3 months, depending on how badly the patients are healing based on imaging. And if it still doesn't heal and goes on to a delayed union, sometimes we'll recommend surgery to fix it. Now, a little bit more of the meat of the topic, which is the elbow ulnar or medial collateral ligament or UCL injury. So the elbow UCL is a structure on the medial aspect of the elbow, and it's actually composed of 3 different bundles that form somewhat of a triangle. The overall function is to provide stability and to resist valgus loading, so again, resist this sort of thing, particularly by slowing elbow extension during the deceleration phase of throwing, which is why pitchers are the most commonly associated with this. Interestingly, the stress seen at this ligament during throwing can be 64 newtons per meter, but the tensile strength in cadaveric testing is only 33 newtons per meter, so about half of that. And so it's interesting that we don't see more of these, or rather that I think could be a good explanation for why we do see so many of these. So it's a very common injury for overhead athletes, particularly baseball pitchers. Looking at the numbers, 15% of minor league pitchers and 25% of major league pitchers have had a surgical reconstruction, so the so-called Tommy John surgery. And about a quarter of all elbow injuries in the MLB are UCL related. But other athletes are also at risk. It's not just baseball pitchers. Quarterbacks, javelin throwers, softball players, and those athletes participating in water polo, gymnastics, wrestling, tennis, or golf are also at risk for it. So our group during residency looked at this through a variety of lenses. And so in this one, we were looking at UCL injuries and throwing versus contact athletes. And what we found here was that men's wrestling actually had the highest incidence of UCL injury per athletic exposure, but that baseball was by far the highest actual injury burden, and that men's football was the other significant contributor. I think the other important thing to note about this is that these are pretty serious injuries. So in the difference between the contact injuries and the throwing injuries, which tended to be ruptures, often led to much more time missed and much more likely to undergo surgery and a much more higher likelihood to have a severe injury than the contact injuries. We delved into a little bit more looking at the UCL injuries of baseball players in the NCAA, and again found that time loss was a very serious thing. And this you can sort of think of as a bimodal distribution. You have about 45% of the athletes who it basically didn't interfere with them. 35% they came back immediately, 5% they came back later in the day, and 5% they lost a day. But the other 55% is that they lost really a significant amount of time, and even 20% were season-ending injuries or losing more than 30 days. So these can be very significant injuries. And now, thinking about the treatment algorithm. So this treatment algorithm is from more of the perspective of either the primary care sports medicine provider or potentially you as a physical therapist. So if there's clinical suspicion of a UCL injury, really the first thing we think about is doing imaging. And the best imaging tends to be an MRI arthrogram or an ultrasound. The ultrasound is a little bit more operator dependent, and so it can have a really good sensitivity, but it may not be quite as helpful. The nice thing about ultrasound though is you can do it dynamically, and so you can really provide valgus stress on the elbow, which can help load it, and you can see if there are any changes at the UCL. But the severity of the tear is strongly related to the likelihood of failing non-operative treatment. And we can think of these tears as either a low-grade partial tear, a high-grade partial tear, or a complete rupture. The tear location, whether it's proximal or distal, does have a very big impact, and the distal partial tears are much less likely to respond to non-operative treatment, with about a 12-fold higher failure rate than the proximal partial tears. It also depends on the sport that they play, but also the symptoms that they have. If they aren't having symptoms, even if they have a complete rupture, we typically don't do very much about it because, again, they're asymptomatic, and the treatment for it is quite invasive and can have a prolonged rehab process. If you The non-operative treatment typically consists of non-throwing PT, avoiding valgus force or strain exposure for about 6 weeks, and then initiating a return to throwing program. So I wanted to go over one sample UCL Recap Protocol, which is one that I like to do. And we can think about this in 3 phases. The first phase over the first 1 to 2 weeks is really getting everything to calm down and to minimize the inflammation and the pain and the swelling and everything else. And the goal of this is really to help with motion, but not to do any loading. So we have to avoid any valgus stress, maybe use a hinged elbow brace or something similar. We use ice, we use a compression sleeve. We try to get everything to calm down. Once it's feeling a little bit better at 2 weeks, then we increase a little bit. And that is the goal of that is to normalize strength and to prepare to move into sports, but not to go back to sports yet. So it's a lot of manual manipulation, it's light plyometrics, it's isotonic strengthening of the elbow. So it's relatively lighter stuff, again, maintaining motion and gently building up strength. And then at 6 to 12 weeks, we'll think about doing a return to sport. But this is highly dependent on what the athlete is doing. If they're throwing a javelin, then that's a huge load to the elbow that will need to go back very slowly as compared to, say, a field like a soccer goalie or a non-pitcher in baseball. They'll have a lot less load placed on their elbow. And so we can think about accelerating a rehab process a little bit faster. And here's one just sample interval throwing program that I liked. Each of these blocks are 3 or 4 days. And so each phase is essentially a week. And basically, each week goes up in distance, goes up in intensity, and goes up in time. And this is a good template. And as long as the athlete is able to do this, they can progress to the next. If they can't, they have to sit out. They basically have to hang out where they are or potentially move back in time just to make sure that they aren't hurting themselves. And we can think about we need to make sure that their goal is a 4 of 10 or less in pain, and that all symptoms subside after 36 hours or so. So if they do need surgery, then sometimes we'll think about doing a UCL reconstruction. And there's many different ways to do this. In particular, I use a palmaris autograft. I use the docking technique, which tries to recreate the kinematics of the normal elbow, which again is this triangle-like structure, but many variations exist. The most important thing is, important things is that it gets the isometric point, so it replicates the kinematics, and then we try to be nice. We try not to have too much handling of the ulnar nerve because that can lead to ulnar nerve symptoms, the numbness, the tingling, the weakness, and also splitting the muscle or getting through it, as opposed to detaching that flexor pronator mass, which can have a little bit longer in terms of recovery. But before, during, and after really any of these, really important thing is communication. So I try to be very specific in my operative notes and in my clinic notes to say, here's the plan here. I'd like the patient to do this, this, and this. Here are goals that I'd like to, and by the time that I see them back in 2 weeks, 4 weeks, 6 weeks, what have you, then I want them to be doing this. And this is where we really depend on the partnership between me as the surgeon, the patient, but also you as the therapist to have really good communication, because you're seeing the patient more than I am. You're really working with them. And so if you have any questions or concerns or other issues, we really, really, really want to know about it, and we want to know about it quickly so that we can tweak things as needed, because in that way we can make some small adjustments that may help the outcome and may prevent stiffness or even, heaven forbid, going back and needing secondary surgery. So with that, I want to thank everyone for their attention, and My information's up here. Again, you can always either give my office a call if you have any patient questions or want to refer a patient. The phone number is probably the best way to do it. If they're already an evergreen patient, they can also send a message via the portal, or they can get referrals from their primary care provider or anyone else. And then you can also, for the therapists or for the other providers, feel free to send me an email if you have any questions. But thank you very much for your attention. Really appreciate it.
All right. Thanks. That was a fantastic amount of information there. I'm just going to stop the share real quick. Or actually, can you stop the share for me? Yeah, a little elbow, potential elbow pain for you is carrying around a little peanut around the house now, it sounds like. So
Exactly.
We had a couple of questions sent in ahead of time. So I'll share those with you. But again, thank you for such a complete just review of kind of elbow injuries as well as the anatomy as well. It was really, really good. The first question was, what should parents be aware of with Little League pitchers in relation to elbow pain? I think you kind of touched on this to a degree during the presentation, but I guess when is a referral to the office or notifying the coach kind of an important?
I think that's a really good question, especially as more and more kids are becoming single sport athletes and just doing lots and lots of throwing. So what we tend to think about is if there is elbow pain that is not going away, and so we think of that at least over several days, then we counsel rest. And if rest doesn't work and you're still having pain, that's when we think about a referral to get referral for us, like to get an X-ray. Because if we see an X-ray at that point, it could be a number of different things depending on how old the patient is and where they are in their skeletal maturity. It can have different implications. Little leaguer's elbow and like the physeal separation can be a bad injury, and it can cause other issues down the line. And so it's important to catch early and work with the parents, work with the athlete, work with the coaches and the therapists in order to really make a good program for the patient. So I'd say that if it's going on for more than a few days and it doesn't get better with rest as well as some ice and some anti-inflammatories, that's when I think it's really worth the referral.
That's perfect. I know a lot of us that are on the webinar here have little kids playing Little League as well. So how this was answered, I think, earlier in the presentation, but maybe you could just sum up a little bit more concisely for this individual. How long does a wrist fracture typically take to heal? Just generally speaking, I guess there's a lot of different.
Yeah, there's a lot of different flavors of wrist fractures. If we get a patient who has say a young athletic patient who has a minimally displaced fracture, typically the timeline for that would be they'll see a provider, they'll get put into a splinter brace, they'll come see us. Usually we'll cast them for about 6 weeks. Sometimes we'll make a little bit of modifications, either going to a removable brace at 3 or 4 weeks if it's truly not displaced and the patient's really able to be adherent. But it's about 6 weeks of pretty strict immobilization, followed by really good mobilization after that, starting range of motion about the wrist. And so they're generally out of play for in the range of 10 weeks, but it totally depends. If it's their non-dominant hand, they're a tennis player, and what they use their non-dominant hand for is just tossing a ball, then it can be a lot shorter. They could probably get back at 6 weeks at that point in the brace. If they have a two-handed backhand, it might be a little bit longer. If they play football or lacrosse as really a contact or a collision sport, then they're going to need to be in it longer and going to need to go back and playing in a brace for longer. And same thing, if you have a wrist fracture and it's fixed surgically, the advantage of the surgical fixation is one, putting it back in the right spot, but two, to really facilitate early range of motion. So after the surgery, typically we'll have people in a splint for about 2 weeks, and at 2 weeks, then we'll get them into a removable Velcro wrist brace and have them start doing range of motion exercises like at least 5 times a day, as well as working on their fingers, so that we can get them back to doing things. The timeline isn't necessarily faster with surgery, but again, the goal is better motion and hopefully a little bit earlier, but the bone still needs to heal.
Right. Well, that's nice if you can have those quality mechanics. That makes a big difference too. Here's a question that's kind of in some ways pits East Coast versus West. The Northwest here with Driveline has been kind of one of the homes of weighted ball training. The East Coast, where you did some of your residency work, is kind of the non-weighted ball training portion of the country. Do you have an opinion or what the research has shown in your studies?
I think it's a great question. I personally don't have a really strong opinion about it. I've had some mentors who have had strong opinions on both sides of it. Uh, the research does not really come down one way or the other. It's basically there's not enough good quality data to either suggest that it's helpful or to suggest that it's harmful. And so I think that there can be some help in it, just to give the athlete a way, basically to be doing something and to give a psychological edge. And so that in itself may be helpful. So I would probably come down gently in favor of it, but always interested in seeing what more high quality data showed.
Yeah. I guess this kind of speaks to kind of like you said, like you're one sport athlete, and it seems like in this region and around the country, we're doing that earlier and earlier. Should players and athletes look to take an off season or to cross train?
I I think yes. I am pretty I'm pretty strongly in the yes camp because I think that doing cross training and taking some time off really does help you become a better athlete in your preferred sport, because it will allow for the rest. It will allow you to push yourself harder when it comes time, but your body does need time to recover. And so that can be, shorter intervals in between seasons, like 2 weeks off 4 times a year, or other cross training. But I'm a big advocate of that.
And then maybe final question here, related to sports. What's the most common athletic injury you're seeing kind of coming out of the pandemic as we sat there and did online school, and for some people they were much less active than normal? Or is there things you're seeing from a elbow, hand, and wrist situation?
We see lots of distal radius fractures for folks who are out there and they're hiking and they slip, or they're skiing and they fall. And so it's lots of these individual activities that people have been doing, but that just end up in calamity. And so same thing with the skier's thumb. People have been doing these wonderful outdoor activities and then just have these bad injuries. So we're seeing a pretty good variety of injuries, and also pretty serious injuries too. So it's not like the pandemic has decreased their activity output. Um, so in many cases, it's gotten people to be more active, which has been wonderful. But with that does come an increased injury burden.
Yeah, being in front of a screen, I think, stresses people out enough. They have to get
Exactly.
out there and do a little more. And full disclosure, I'll be having surgery with you in the fall, so I have to get through a water skiing season first. But as you mentioned earlier in the presentation, the UCL or skier's thumb is what I got from a very vigorous co-ed soccer goalie adventure a couple years ago. So um, I think that wrapped up all the questions, but I appreciate you, taking the time to put together a great presentation, and then also even sharing some of your own research, which is maybe one of the firsts on our webinar here. That's great. You have his contact information in the slides, but we'll also have it in the presentation notes and also on the YouTube notes. So make sure to share this with friends and faculty and colleagues, and we'll get this out there. But I really appreciate you taking the time to do this, and we love the care that you're showing for our patients, and just the openness to bringing people into shadow and learn more about the elbow, wrist, and hand from a physical therapy standpoint. It's been fantastic.
So it's great to be here, and thank you very much for having me.
All right. Thanks so much.
Have a good day.